Joining us today in MCDA's next webinars in our webinar series. Today's topic is making sense out of the physician quality reporting system. We're joined today as the presenter with Chris Calderon. My name is Bruce Mackey. I am today's moderator. Briefly today, I want to just talk a little bit about MCDA services. Anyone who has joined us for any of these webinars has seen this slide multiple times. But just going through services that MCDA offers, we offer meaningful use support as kind of our bread and butter. Any stage or any year, we are able to help you in the meaningful use space. We offer the security risk assessment, which is an embedded part of our meaningful use support. But if you have everything else already figured out with meaningful use and just need help with the security risk assessment, we can offer that as a standalone service. Targeted process optimization, which is essentially a stripped-down version of Lean that is applied to any workflow analysis or redesign effort that you need help with in your office. Audit preparation, if you have been alerted by either Medicare or Medicaid that you are been selected for a meaningful use audit and need some peace of mind or some help addressing the requirements with that audit preparation, we can assist with that. And another item that needs to be added to this list now is what we're discussing today, which is our new PQRS support as well. And Chris will be talking at great length on that. Today's outline of discussion, we are going to cover the reporting requirements in PQRS, the reporting methods, the impact of failing to report. We'll be discussing the value-based modifier and how it relates to PQRS. Measure selection considerations, the reporting deadlines, and some key considerations, and finally how to report once for meaningful use and PQRS. And finally, at the end of the presentation, we will leave some time to answer some questions. We also have another colleague of ours, Mandy Carr, is here in the room with us as well to assist with any questions that come up. So with that, I'm going to turn things over to Chris and get started.
Thanks, Bruce. And before I get started, I just want to thank all of you for spending part of your day with us. We hope that this will give you a good high-level overview of what PQRS is all about and what you'll need to do to get started on your PQRS journey. So PQRS obviously stands for Physician Quality Reporting System. It pertains to eligible providers who provide services or bill under the physician fee schedule. I'll talk more about that shortly. It does include those providers in private practices. It does exclude certain providers that are working in facilities, including excluding providers that provide all of their services in a rural health care or rural health clinic or a FQHC. Essentially what we're talking about now is that we have nearly 500,000 providers that are already receiving some type of negative payment adjustment for not participating in PQRS. So they're receiving that in 2015 for care delivered in 2013. And it's very important to realize that CMS is going to continue on their quality journey and link nearly 50% of all provider payments to quality initiatives by the year 2018. So again, PQRS is CMS quality reporting program. There are no more incentives. So 2014 was the last year for payment incentives. So really what we're talking about now, helping you get positioned for, is to avoid the negative payment adjustments that will come in 2017 for the care that you're delivering now in 2015. Very important point, and I'll touch on this as we go through the slide deck a little bit later, but PQRS Meaningful Use are two separate programs. PQRS really applies whether you're pursuing meaningful use or not. It is possible to report once for both meaningful use and PQRS, which I'll cover a little bit later, at least for those that are participating in the Medicare EHR incentive program. So eligible professionals are really, again, any EPs that are providing services that are based on the Medicare physician fee schedule. And there's really three categories of eligible professionals, or EPs. You have physicians, therapists, and practitioners. So those are essentially your eligible professionals, or EPs. Important points about some of the PQRS measures, and we'll go into more detail later on. There are 250 measures for 2015. The good news is that you don't have to report on each of those measures. You're going to be choosing measures that, again, are based on your practice specialty, your scope of practice. You'll be choosing measures that are consistent with the care that you deliver in the care setting, and even aligning with your quality improvement initiatives. And you'll consider those measures, of course, that you can easily, if I use the term loosely, easily report within your existing workflow, which is particularly important when we talk about reporting via the EHR. So as we go through the slide deck, and you'll know if you've downloaded the PDF file, there are links included in throughout the slide deck. So hopefully these resources will be helpful to you. Now, the 250 PQRS measures for 2015 are aligned with one or more of the 6 national quality strategy domains. This is important to consider when we talk about the specific reporting requirements a little bit later on. But essentially, there are 6 NQSs, and again, the 250 PQRS measures align with one or more of those NQSs. So as we make sense out of PQRS, this is just kind of some of the takeaways I gleaned preparing our slide deck today. But obviously, there's 2 reporting options. So you have an individual option and a group option. That's not to be confused with individual measures versus group measures. And then there's a difference between the reporting option, i.e. individual versus group, versus the reporting mechanism, whether it's the EHR, the registry, or a web interface. And we'll talk about all of those in a little bit here. So the reporting option that you choose, whether it's individual or group, will influence the type of reporting mechanism that you can use. And there's some key dates that I just want to surface straight away here. Just realize that PQRS is a 12-month program. It's based on the calendar year. So, for example, when we begin reporting in the first quarter of 2016, we're reporting on care that you delivered in 2015, starting on January 1, 2015, and ending on December 31st, 2015. So you really can't start reporting until January 1 of 2016. By and large, most reporting begins and ends in that first quarter. For example, if you're reporting via the EHR, you have to have your data submitted by February 29th. So apparently we have an extra day in January or February this year. So again, the 2 reporting options are group and individual, and I'm going to go over the group reporting option first. We also refer to the group reporting option as GPRO. So basically, a group practice is defined as a single TIN or tax identification number with at least 2 individual EPs. And the important point here is that those EPs, those individual EPs, must have reassigned their billing rights to that single taxpayer identification number. So if you're going to report as a group practice, the practice as a whole participates as a group practice. And again, that's available to any practice with 2 or more eligible professionals, or EPs. And this is very important. So if you're going to report as a group practice, you must have registered by the deadline of June 30th, 2015. So you must have registered for an IACS account, which is now called the IEDM, or Enterprise Identity Management account. And not only must you have registered and indicated your desire to report as a group practice, you must also have indicated the mechanism that you intend to use, whether it's the registry or the web interface or the EHR. If you did register by that deadline and you did indicate, for example, that you want to report via the EHR, you cannot make a change to that reporting mechanism. So you're essentially committed to what you indicated when you registered for that to report as a group practice. So I want to go over the 5 specific reporting mechanisms if you're going to report as a group practice. The first is the qualified PQRS registry. So I have a MAV warning there. I'll come back to that in a second. So the registry is one way that you can report. The web interface for group practices with 25 or more providers is another method. And then you can also report through the EHR. So I just want to make a special note about, or mention about the EHR. You can report directly through the EHR, which means you're simply going into your EHR, getting the data, getting it into the proper format, and submitting it directly to CMS. Or you can use what we call a DSV, a data submission vendor, and that's a vendor that loads that information or provides that information to CMS on your behalf. And then when you register, if you did register to report as a group practice and you indicated the EHR option, it doesn't matter if you do it directly or through a DSV. The other method to report as a group practice is via a CMS certified survey vendor. So you're paying for this service and you can report that way. So if you're participating in the consumer assessment of healthcare providers and systems, that's another option that you have for reporting as a group practice. So let me just kind of break this down for you, the group reporting options or mechanisms. So if you're reporting via registry or an EHR, you need to report at least 9 individual measures. So you're reporting on those measures from that 250 measures list, and those 9 measures must touch at least 3 of the national quality strategy domains for at least 50% of the group's practice, the group's Medicare Part B fee-for-service patients. So that 50% applies to the registry. It doesn't apply to the EHR because with the EHR you're submitting all your payers. So, but the 9 measures do apply and the 3 national quality strategy domains do apply. If you're reporting via the consumer assessment of healthcare providers or the CMS certified survey vendor option, you only need to report 6 measures that cover 2 national quality strategy domains. The other option is a web interface option, and again, that's only available to groups of 24 or more providers, and that's essentially part of your claims information. Part of your claims information will be pre-populated, and you're entering the rest of that data directly into that web interface. Here is additional information if you're going to report as a group practice. If you register to report as a group practice by the deadline and you choose to report via the EHR either directly or through a data submission vendor, there's a link for additional information on that reporting mechanism using the group option. So if we're reporting as an individual or individual EPs, you're reporting separately for each provider. So again, all providers participate as individual EPs, and you're selecting 9 measures per provider. And the point I want to make here, it says no registration is required if you're reporting via the individual option. What I really mean to say is that you don't have to tell CMS that you intend to report as an individual or individuals. There is an additional requirement, however, if you're reporting via the EHR option directly as an individual and not using the data submission vendor. So if you're going to report via the EHR as individual EPs, you're reporting directly. In other words, you're going in, getting the data and submitting it to CMS directly. You will need to sign up for that enterprise identity management account. And the reason I mention this to you is because it could be a lengthy process. So you want to, I mean, we're getting into fall already. We are into fall, and it could take a little while to get that registration completed. So I wanted to point that out, and there is a link to that registration guide as well. So in terms of individual reporting option, you have 5 mechanisms that you can report through. One is the Medicare Part B claims method. I will mention regarding the claims method that this is an option or a mechanism that will not be supported by Medicare indefinitely. They have indicated that this will be something that is going to go away eventually. You can also report via qualified PQRS registry. Again, I'll come back to what the MAV warning means in a second. And then as with the group option, you can also report via the EHR. You can do that directly, or you can use a data submission vendor. You can also report via a qualified clinical data registry. The other thing I want to mention on this, and I'll go into more detail, if you're going to report as an individual and you select the qualified PQRS registry option, you can report what we call measure groups. And I'll talk about measure groups here in a second. So a little more detail on the individual reporting mechanisms. So in terms of claims and registry and QCDR, you're reporting 9 individual measures, just as you would be with the group option, and those 9 measures have to cover at least 3 of the national quality safety domains, and the 50% of the providers' Medicare Part B patients does apply, with the exception of the EHR, because as with the group practice EHR reporting option, you're reporting all your payers to the EHR. So again, on the registry, you can report via measures groups or a measure group, and again, measure group option can only be used with the registry reporting mechanism. If you do choose to use a measures group, it's kind of nice because you're only reporting 1 measure group on a 20-patient sample, a majority of which, or at least 11 of the 20, must be Medicare Part B fee-for-service patients. So what is a measures group? Well, essentially, there are 22 measure groups to choose from in 2015. Each one of those measure groups, for example, preventative care, may have 4 or up to 10 individual measures linked to it. So if you want more information about measure groups, there is a link in this slide. But just keep in mind, the takeaway is that the measure group option only applies to individual reporting. It doesn't apply to group practice.
Can I do this or what?
And it only applies if you've selected the registry reporting mechanism. Another important note to make is this requirement about a cross-cutting measure. So this is new.
Sorry.
And this only applies to the claims and registry reporting option. So it applies to claims and registry if you're reporting individually, and it would apply to registry if you're reporting as a group practice. And what the cross-cutting measure means is that any individual provider or group practice is required to report at least one cross-cutting measure if they've had at least one Medicare patient with a face-to-face encounter. So, and of course, CMS defines a face-to-face encounter as any instance in which the EP bills for services that are associated with face-to-face encounters under the physician fee schedule. So there's a link to the cross-cutting measures list on here. And I just want to point out that although Medicare is very clear in their language about the cross-cutting measures requirement for the claims and registry reporting mechanism, they specifically do say that if you're reporting via the EHR, whether it's individual or group, that the expectation is that you'll report at least one cross-cutting measure. So now here's where, remember I told you I'd talk about MAV? So here's where MAV comes into play. MAV stands for Measure Applicability Validation. Really what it means is that if you report less than 9 measures, or you report 9 measures across less than 3 of the NQS domains, MAV will kick in. And it's a process that CMS uses to determine if there were additional measures that should have been reported that for whatever reason you did not report. So the good news about MAV, if there is any good news, is that it only applies to the claims and registry mechanisms of reporting. And it kicks in basically when we're talking about claims. So if you submit 1 to 8 measures or less than 9, MAV will kick in. Or if you submit your 9 measures, but there are less than 3 national quality safety or strategy domains. And the other instance where MAV will kick in for the registry or the claims reporting mechanism is if you had at least one Medicare patient face-to-face encounter and you did not include a cross-cutting measure. So that's really the only 3 times that MAV will kick in: if you report less than 9 measures, or you report 9 measures across less than 3 of the NQSs, or if you had a face-to-face encounter and you did not include one cross measure. And again, takeaway here, MAV only applies to the registry and the claims reporting mechanism. So I kind of just said that, so I'm gonna skip through that. I want to come back or pivot back to my comments about the relationship between PQRS and meaningful use. Again, just to reiterate, these are 2 separate programs. You can report once for both programs, as I mentioned, at least to the extent for those of you that are participating in the Medicare meaningful use program. The point I want to make here in the middle bullet point is that the easiest way to do this is to report directly, or even a data submission vendor, someone does it on your behalf. But the point is you can report directly through your EHR. Now, some more information on reporting just once. You're submitting basically one set of EQMs to satisfy the CQM component of meaningful use and PQRS. As I mentioned, this only applies to those participating in the Medicare meaningful use program. Important point I want to make here is that, as I mentioned earlier, PQRS is a 12-month program. Meaningful use is 90 days. But if you want more information on reporting just once, you can refer to this nicely titled document, How to Report Just Once, or Report Once, and the link is on this slide. So a little context here. The research and our experience is quite clear. It tells us that providers that have been participating successfully in meaningful use generally have a good starting point or a solid foundation for getting ready for PQRS reporting. And so if you've been successful with meaningful use, you really shouldn't have a lot of difficulty reporting for PQRS. But I just want to reinforce the point I made earlier that the incentive train has really left for PQRS. It's simply you're in a position now where you're trying to avoid negative payment adjustments for 2017. So if you are going to report just once, this is very important. You're going to want to use the July 2014 version of the ECQMs to report really in the first quarter of 2016. I want to talk briefly about a thing called the value-based modifier. So this is yet another quality program that could potentially penalize you in addition to the negative payment adjustment you would get for not successfully participating in PQRS. So the VM program requires providers to meet goals related to quality, cost, and the good news is that it uses PQRS reported data. So I'm going to come back to that in a second. So what's happening now with the VM program is that it started earlier, but it's really going to be phased in to nearly everyone in 2017. So it'll be applied to solo practitioners and group practices of 2 or more providers in 2017. Now, a key point here is that if you are reporting PQRS, you do not have to do anything additional for meeting the value-based modifier requirements. CMS will do that for you. So essentially, there are some pitfalls if you don't report for PQRS. So you're gonna get hit if you don't successfully report for PQRS in 2016 for the care you delivered in 2015. You're going to get hit with a negative 2% payment adjustment in 2017. That's in addition to another 2% that you'll get from the value-based modifier program. So, and then if you're in a group practice with 10 or more providers, you're going to get hit. You could get up to a 6% penalty. So it's pretty significant. So remember my comments that earlier that CMS has really heightened their march to link quality to reimbursement, and so we're seeing that now. But I think the good news is I don't think the reporting requirements are strenuous. Again, because if you're reporting PQRS, you will satisfy the value-based modifier reporting requirements. So I'm going to kind of slow down a little bit here and talk about a roadmap or a plan for getting started on your PQRS journey. So I think the first thing you're going to need to do is consider what reporting option is available to you, whether it's group or individual. And of course, if you have not registered by that June 30th deadline, the group option is not available to you. So then the other thing that you'll want to do is start looking at the appropriate PQRS quality measures that you're going to report on. And again, you're considering things like practice, scope, and specialty, care setting, even maybe what your quality improvement goals are, and also what might be the easiest measures to report on based on what you're what's available in your EHR, for example. And if you are going to report via the EHR, you're going to want to make sure that your workflow is set up in a way that you capture those measures that you said you're going to report on. But my takeaway from this slide is really you need to start thinking about developing what I call a PQRS action plan, which brings some clarity around what it is that you're going to do, who does it, when it's done, how it's done, etc. And so that's where we can kind of come in and give you some guidance. So what we provide clients and prospective clients is we'll help you identify which measures you're eligible to report on, which measures you should report on, and then we'll also look at helping you identify the most appropriate and most efficient reporting mechanism. And we'll also work with your EHR vendor as needed to make sure that you're set up to optimally and successfully report. There are a number of additional resources that are linked on this slide. And so PQRS Getting Started document, the measure codes document, which I referenced earlier in the slide, information on MAV, and then CMS has a really good FAQ section as well. So I know this was kind of a high-level overview, but my intent, I think our team's intent, was really to help you heighten awareness around some of what we perceive as a lot of complexity and confusion around PQRS. So we want to get you thinking. There's still plenty of time. So it's September 29th, and for example, if you're going to report via the EHR, you have until February 29th, 2016 to report. So it's not too late. I think it's the ideal time to really start thinking about what do I need to do, how do we do it, and what resources can we pull together. So looks like we're going to end a little early, which is good. Maybe we can take some questions. I just want to reference our contact slide. So these are the three key people that are really building and delivering our PQRS service offering. And if you want to reach us, the best way to reach us is email directly, because we're not always at our desk, and we can probably get to you quicker if you email us. So with that, I'm going to stop talking for a minute, and we'll look at questions, and we'll see if we can answer any.
All right, thanks, Chris. I didn't mention on the front end of this that we'd be keeping the lines on mute, although as most of you heard through half of this, there was some noise, so I apologize for that. I think we've got the lines quieted now. If you have any questions for Chris or Mandy, please go ahead and type those into the questions box in the GoToWebinar interface, and we will go ahead and get those answered now. I'll give folks a few minutes to put their questions in. Most of the comments thus far were complaints about the noise in the background. All right, one question has come in. Do EPs have to report PQRS if they do not do face-to-face visits? Example, cardiologist who reads tests only.
Yes.
Simple answer. Yes. All right.
If they're getting reimbursed, if they're getting paid by Medicare under the physician fee schedule, then they have to report.
All right. Thank you. Next question. Do you provide data mapping from the EHR to upload into CMS?
I think, hi, everyone, this is Mandy here. I'm not sure if you're referring to the QRDA file to be uploaded to CMS. I think that's what you're referring to. Your EMR or EHR should have the capability to generate the QRDA1 or QRDA3 file, which once you generate and before the deadline, as Chris mentioned, February 29th, if you are reporting via your direct EHR, then you'll be uploading that file via your EIDM account on the PQRS portal. So you can submit QRDA1 or QRDA3 file.
Also, keep in mind, if you're working on with the certified product, all certified products are supposed to have the ability to generate the data in the proper format for PQRS submission.
Correct.
I don't know if that answers. I think.
Hopefully that answers your question.
All right. We had a question about the cost for our service. I can answer that. It would be best if you just email one of the folks directly. That's on the contact information slide that you have right now. There's a lot of variables that go into determining the cost for the PQRS service. So if you contact us, we'd be happy to get you a quote. Next question. I have 2 LMSWs that I was told did not have to report for anything, but now I am getting the money taken out of MR. How do I get them started then, since time to start has expired? So it sounds like they probably did not report. Their penalty must have started this year, so that's the 2013 program year.
Oh yeah, so keep in mind PQRS is a 12-month program. The nice thing about it, there's always a reset at the beginning of the year. So if you're already getting hit, there's nothing you can do.
If you're getting hit for now in 2015, that would have been for your year 2013, for not reporting for year 2013. So that you can't unfortunately retroactively report. But you still have the option to report for 2015 in order to avoid the 2017 payment adjustment.
Yeah, keep in mind, so PQRS is a 12-month program, so there's always a reset. And the general rule is you're going to be reporting at the start of each year for care delivered in the previous calendar year, and then the payment penalty will reflect the next year. So you're going to report in 2016 for care delivered in 2015 in order to avoid the 2017 payment adjustment. So again, if you're already getting hit, the train's already left. There's nothing you can do, but there is a reset.
So just to add to what Chris just said, so you still have the option to report now. Unfortunately, it will be too late to report for 2015 if you were considering a claims option, because you will not be able to meet the 50% threshold since we are already in fall now. And so you do have option to either report via registry or the direct EHR that possibly to meet for the 2015 reporting period.
Okay, thank you. Next question. For someone who plans to retire in March 2016, am I eligible am I eligible to do or just stop the process now? So someone's retiring early next year.
So you will not be billing for, obviously, I mean, you might be getting the penalty now if you have not reported for year 2013, but in future, if you're not in practice, then you will not be getting payment.
For this person, the 2015 program year doesn't really have an effect on it, because that penalty is not going to hit until 2017.
So yeah, so if you're leaving the practice, then if you're done, then there's no harm, no foul, basically. So in 2016, the impact in 2016 would be on care delivered in 2014 for failure to you didn't report in the first quarter of 2015. So what you're saying, if I'm leaving the practice in 2016, why report in 2015? You're reporting the first quarter of 2016 for care delivered in 2015.
I think that's something you might, because you have, you're still in practice, you are billing Medicare and you are an eligible professional, then it's possible that you can still get, penalty for the year 2017. So that's something that you want to explain your individual situation to QualityNet. PQRS help desk, they can determine if you will be subject to the 2017 payment adjustment or not.
Okay. Follow-up question from our attendees. What if you have both EMR and registry, but they are not the same system? Is it better to submit one way over another?
So if you are considering, if you have not registered as a GPRO and you are not reporting via the direct EHR, so you can report more than one method unless you are registered for GPRO, then you are stuck with that method and you must report via the same exact method when you registered for GPRO, whether you chose registry or EHR direct. But if you are considering to report via registry as well as direct EHR, yes, you can. You can report via two different methods as long as you are not in GPRO practice. And CMS will then analyze the data that's most favorable to you. But keep in mind that you are to report for whichever method you choose, or choose more than one method, you are to report for the full year. It can't be like that you do first 6 months via registry and the last 6 months via direct EHR or claims. So it should be the full year via both methods that you choose.
Okay, thank you, Mandy. Next question. We are pediatrics. We don't bill Medicare. Does this still pertain to us?
No.
Easy answer. Yeah, if you don't bill Medicare, PQRS doesn't really pertain. Next question. Are there specific measures that surgeons and other specialists need to report?
Right now, you want to look at the measures list that are out there on CMS, and I think Chris has provided the link to measure codes as well in the slide deck. CMS is currently working on specialty measures, but there are some measures that specialists do have a little bit of harder time to pick the ones that are applicable to their scope of practice. But there are measures that are available that you possibly might not have the 9 to report on, but you want to report whichever ones you can, maximum number, and then you are subject to the measure applicability, the MOB process, validation process, and then CMS will analyze if there were additional measures that you could have reported, or then you're subject to the MOB process. But you are to report on the required, based on what method you choose, whatever the required requirements are, based on whichever one measures that you believe that you can report on. So right now there's no measures that are specific to each specialty. They're still currently developing the specialty measures.
All right, thank you. And a follow-up question from the same attendee. This is a question that we run into with meaningful use all the time too, because it's the whole reporting year and program year and whatnot can be very confusing. Just so we are clear, 2015 reporting is for services in 2014?
No. So if you reported in the first quarter of 2015, you were reporting on care delivered
in 2014.
In 2014, with the payment payment adjustment occurring in 2015. So what we're saying now is that you're going to get ready to report in the first quarter of 2016 for care delivered in 2015 calendar year. So it started on January 1, 2015, ended on December 31st, 2015. So again, you're reporting that in the first quarter of 2016 in order to avoid the payment adjustment in 2017. So think of it in 3 years. You're reporting on care delivered in the previous years in order to avoid the payment in 2 years. Does that make sense? So
yeah. So you have deadline. You have each, depending on what method you're reporting, you have one of the EHR direct method. If you're reporting via EHR, then you have the deadline of February 29th. But you can report prior to February 29th in either, in any time in January or prior to, in February prior to 29th, but you have until February 29th to report for your 2015 data.
Right. But generally you can't, since you're reporting on a calendar year of care for the previous year, you can't start reporting until after December 31st.
Correct.
Of that year. So again, you're only trying to avoid the negative payment adjustment in 2017 by reporting for 2015 care in the first quarter of 2016.
So that's it for questions thus far. If anyone has any additional questions, we do have some time yet. We can stay on the line. Go ahead and put those into the box. You can also email if you have any questions after the presentation. Feel free to email the folks on your screen right now. We'd be happy to answer. We just had another question come in. Can an individual attest now for meaningful use and then use attestation for PQRS in January for 2015? 2016, she sent a clarification. So can an individual attest now for meaningful use and then use attestation for PQRS in January of 2016?
But for PQRS, you cannot attest via attestation. That is for meaningful use. So if you are, for your core and menu set objectives, you will be attesting via, depending on, I'm not sure if you're in the Medicare program or in the Medicaid program. For the Medicare program, you will be attesting via the federal site, via attestation for your core and menu. And if you want to report for your CQMs, you will be reporting for, if you want to report for the PQRS as well as meaningful use, then you will choose the option to electronically report, and then you'll be reporting that via the PQRS portal, which that's what Chris talked about, that requires the EIDM account if you're reporting electronically for both programs. But for PQRS, you do not report via attestation. That's only for meaningful use. And if I'm not wrong, I believe right now, if you're in the Medicare program, you're not even able to report currently for meaningful use because the site is shut down, so federal site, and so that won't be open until first quarter of 2016.
Yes, that's correct. All right. Hopefully that answered the question. The way I'm reading this, I'm wondering if this particular attendee was asking about the ability to attest to meaningful use right now, but then hold off on submitting their CQMs until January of next year, which in a normal year where the system is up and running, that would be the case. You could, if say you were doing a 90-day attestation, if you were a stage 1 year 1 provider, you could do your 90-day attestation some point during the program year, not report your CQMs, and wait to do the kind of two birds, one stone thing on the federal site, on the PQRS site. So you'd wait until January to submit your CQMs, and that would give you credit for PQRS as well as meaningful use. So your meaningful use attestation goes into a holding pattern until those CQMs come in. Is how that works in a normal year. This is anything but a normal year. Another question that came in is 90-day attestation possible for stage 1 year 2 this year? We're venturing into meaningful use at this point. Hard to answer that one. Technically, the way the rule stands right now, that is no. We are, as the hard and fast rule, we are anyone that is beyond stage 1 year 1 is technically in a year-long reporting period. We fully expect that to change. We are waiting for what's called the modified stage 2 final rule that could arrive literally any minute now. And we fully expect that to change the reporting period in 2015 to 90 days for everybody. So when that final rule comes out, as long as that language is there, then yes, it is a 90-day attestation for a stage 1 year 2 this year as well. But again, that's only once the final rule arrives. Follow-up question. So meaningful use is not being reported until first quarter 2016. Is that correct? In the Medicare EHR incentive program, that is the case. The federal system is not accepting any attestations right now, and it is because of the modified stage 2 changes that are coming at us. So if you're in the Medicare program, nobody can attest to meaningful use until it looks like January of 2016. As it stands right now, the Medicaid system, the CHAMP system, is still accepting stage 1, year 1 attestations. I'll give one more minute for any additional questions. While we wait, I will mention that we are recording today's session, and this will be posted to the MCEDA website, just like all of our past archive sessions. If you go to mceda.org, navigate to the Resources tab at the top, and then scroll down to Webinars, you will see in the next day or two, you should see this recording. The slide deck from today's presentation is already there and can be downloaded at will. And all of our past archive sessions and slide decks are also located on that same page. Follow-up question to the last one, but time has passed for EPs to switch to Medicare from Medicare to Medicaid, correct? Yes, that is the case. If you have already received one payment under one of the programs, so if you have already successfully attested to meaningful use under Medicare or Medicaid, you are now locked into that program. As of March 20th of this year, the ability to switch between programs was cut off. However, if you have not received an incentive payment under either of the programs, you still can choose which program that you're going to participate in. All right, last call for any questions. And we'll go ahead and wrap things up for today. I want to thank everybody for attending today, and thanks to Chris and Mandy for their expertise. We sincerely appreciate it. If anyone has any additional questions, comments, concerns, feel free to contact us here on any of the names or numbers listed here. You can also go to the mceda.org site. And our phone number, 888-MICH, M-I-C-H-E-H-R, will also get you to our general info line, and we'd be happy to answer any questions you have. All right, with that, we will wrap up. And again, thank you, everybody, for attending. We hope to see you again soon.